Okay, it's 3 p.m. now. We will start the webinar. Dr. Chua, Dr. Ke, are you all ready?
Yep, I am.
Okay.
Chua is back?
Yes.
Okay.
So good afternoon, everyone. I would like to introduce the session today. We are in the month of September dedicated to the subspecialty of infectious disease. And specifically today, we have a very interesting topic called rabies, a disease of only animals. And I'm pleased and honored to introduce the chairperson today. I would like to welcome Dr. Ke Hong Bee, who is a consultant of infectious disease unit in Hospital Raja Permaisuri Bainul Ipoh Perak. She heads the unit under medical department, and she will be chairing the session for our speaker, Dr. Chua Hock Hin. Now, Dr. Ke is a very familiar figure in the state of Perak especially, and I'm not surprised the whole nation. She completed her subspecialty training in 2005 and furthered her fellowship in St. Vincent Hospital, Sydney, Australia. Her list of publications is numerous, and she also stands in the development group as a member for many CPGs related to infectious disease in the country. And without further ado, I would like to welcome Dr. Ke. The floor is yours, Dr.
Thank you for the kind introduction. Hi, everyone. Good afternoon, ladies and gentlemen. Welcome to the Malaysian College of Physicians medical webinar for the month of September 2023, featuring infectious diseases. All right. And today we are indeed fortunate to hear from a distinguished speaker on an ancient infection, that is the rabies. Rabies is a neglected tropical illness and known as the world's deadliest disease, with almost 100% fatality rate once patients become symptomatic. And now it gives me great pleasure to introduce my dear friend, Dr. Chua Hock Hin, who is a consultant infectious disease physician. He is the state and infectious disease unit head in Sarawak General Hospital since 2009. Dr. Chua has been actively involved in clinical trials and had numerous publications. Most importantly here, Dr. Chua has first-hand experience in managing rabies in Sarawak since the outbreak was declared in July 2017. And I must let you all know, within the ID fraternity, Dr. Chua is our important reference person when it comes to rabies. So without further ado, we'll invite Dr. Chua to start his presentations. The floor is yours, Chua.
Yeah, thank you very much, Dr. Ke, for the kind introduction. Thank you very much for inviting me to talk in this webinar. It's indeed my pleasure to share my knowledge with you all about rabies. All right. So, okay. Okay. So we'll start with the epidemiology of rabies in Malaysia. As you can see in this map here, before 2015, in the World Health Organization map, Malaysia, there has been absence of dog-transmitted human rabies based on this picture here. All right. So the blue one denotes cases where there are dog-transmitted human rabies cases. So in 2015, Malaysia lost its rabies-free status partly because of the rabies outbreak declared in Perlis, Kedah, Penang by the vet department. And if you all remember, it was first detected in Perlis in August 19. Subsequently, on September 8th, it was found in Penang. All right. Rabies in Sarawak, we diagnosed it through human rabies cases in late June 2017. Most of them are children, all right? And by 1st of July, this rabies outbreak was declared in Sarawak by our Director General of Health. And by 28th September 2018, a year later, detection of rabies in dogs population throughout Sarawak. So if we look at the incubation period, in which the incubation period is around 4 to 6 weeks, but in around 3 to 8 weeks, and dogs treat another 3 to 8 weeks. So we postulate that likelihood rabies in dogs population was present around February 2017. What we found in Sarawak is that we found human rabies, and after that we also found rabies in dogs and cats. So it has been a major public health issue in Sarawak since June 2017. We are ill prepared to face this epidemic in 2017 as we didn't have RIG at that time, not in Sarawak state, and we nearly ran out of rabies vaccine. Yeah, that's why we are very careful with the usage of rabies vaccine and our assessment of animal bites. And in Sarawak, we diagnosed rabies through human rabies cases. And up to September 2023, Sarawak has reported total 72 laboratory confirmed human cases, mainly adult cases, and around 22% of the death happened in 2023. And almost all that died did not have post-exposure prophylaxis post-bite. So this pyramid is very important because when you see human rabies case, it is just tip of an iceberg. So there will be a lot of humans exposed, and there are tens of thousands of undiagnosed animal rabies cases per year. So following in 2017, if you all remember, rabies case involving a dog detected in Taiping. 2 girls were in hospital for checks. I think it happened in Kuala Sepitang. And following which in 2019, Taiping again declared rabies infected, where they found dogs infected with rabies. All right. And in last year, around 10th of April 2022, death due to rabies reported in Petaling, Selangor. So what is puzzling is that there has been animal surveillance done by the vet department where there's dogs and bats were all tested negative for rabies. All right, but the clinical features of that patients do suggest it is rabies. All right. So what are the similarities between the northern part of Peninsular Malaysia and Sarawak? Basically, it's because we bordered a country whereby rabies has been endemic or has been around and still hasn't been eradicated. So if you look here, Perlis, Kedah, even parts of Perak, Kelantan, and Terengganu, all bordering lower part, southern part of Thailand. And here in Kalimantan, actually, before we knew that there is rabies in Sarawak, actually there has been a lot of rabies cases going around since 2014 to 2016 reported in West Kalimantan. And the first town that actually reported case of human rabies is actually here in a town called Serian, which is bordering West Kalimantan. So I'll go through 2 cases with you all, which I think is very, very important. Case number 1 is a 62-year-old man staying in Serian. He's an ex-smoker. His medical problem is hypertension. And as you can see in the timeline of the event, on the 13th of April this year, he started to feel unwell with fever. On the next day, he had dysphagia associated with unclear speech. And on the 3 days later, he developed cough, vomiting, further drop in GCS, in which there's been a lot of secretions, and he had respiratory distress and he had to be intubated. And his blood pressure dropped post-intubation and he was put on inotropic support. So if you look at the clinical presentation of the patients, the patients looks like maybe is having a stroke to a doctor who is managing that patient, all right? And the patient can't give much history because at that time he's very unwell, all right? So the diagnosis at that time was to rule out CVA with aspiration pneumonia. And patient was referred down from Syrian to Sarawak General Hospital for management and CT brain. And CT brain didn't show any bleed, no ischemic changes. So the case was referred to our neuromedical colleague. So case reviewed by our neuromedical colleague on examination, tone were normal in all 4 limbs. Ankle, knee, bicep, triceps reflex were absent. Plantar both downgoing. No neck stiffness. So MRI brain was ordered and he underwent lumbar puncture. And impression at that time given by our neuromedical colleague is to rule out Bickerstaff encephalitis. All right. I'm sure you all know what is Bickerstaff encephalitis. It is autoimmune, central and peripheral, usually linked with the brainstem areas. It could be a variant of Miller-Fisher or Guillain-Barré syndrome. So on the 19th, 2 days later, the MRI brain and brainstem showed a well-defined non-enhancing T2 flare hyperintense foci at bilateral frontal white matter region. LP done, opening pressure is about 23, clear and colorless, only 1 cell count, all lymphocytes, protein about 0.35, which was within normal range, chloride about 140, glucose 6.05, and the glucose ratio was actually more than 0.5. And he was also counseled to send for CSF viral panel to private, and it was negative for all common viruses and some bacteria. And if you look at his chest x-ray, actually his chest x-ray looks fairly clear without much evidence of aspiration pneumonia. So progress of the patient, he was put on trial of PSB mode, but he had apnea, noted to have very labile heart rate and BP, bilateral rotational nystagmus, bilateral facial weakness, power upper limb 4/5, lower limb 2/5, reflexes absent. So decision was made to give him IVIG at this dose for 5 days, and noted heart rate of 42 to 46. GCS still remains poor. Oral had a large amount of secretions because patient is ventilated. And on the 24th of April, his GCS dropped further, bradycardia needing IV atropine, but there has been no history of animal bite. All right. So despite IVIG, his condition deteriorated. All right. So no history of animal bite based on history given by his family, not responding to IVIG, deteriorating. He is a male from Syrian, reflexes all absent, MRI brain not suggestive of any definite pathology, CSF no cytoalbumin, no logic dissociation. So decision was made, why don't we investigate for rabies? And proceed for investigation, and true enough, rabies virus saliva detected, PCR detected, and rabies virus in knuckle biopsy detected, and family was counseled for best supportive care. So this is case number 1. All right. So case number 2 is a 51-year-old man who stays in 10 Mile, Kuching. So it's 10 Mile is quite near to Kuching. All right. He's an active smoker. He has no non-medical problem. Timeline of event. All right. On the 21st of August, just happened recently, about 2 weeks ago, he had sudden onset of right hand weakness and numbness associated with pain. On the 22nd of August, he went for a massage, okay, because of the pain. On the 23rd of August, he went to CGP and was given painkiller and injection. On the 4th of August, his pain get worse and he had neck and back pain as well. All right. So he went back to see the GP. Hey, how come you give me painkiller injection? My pain get worse. All right. So the GP referred him to see an orthopedic surgeon. All right. So an X-ray of cervical region was normal. And now he complained of bilateral hand numbness. 3 days later, he had dysphagia and had difficulty in swallowing. And on the 30th, he's getting weaker. He need to walk with assistance. He was given IV drip in the emergency department. He felt better after the IV drip and he was discharged as giddiness of unknown cause. And on the 2nd of September, he was admitted to private hospital, seen by a neuromedical specialist. So on examination at that time, he had generalized hypotonia, areflexic, power 1/5 in all 4 limbs. MRI, brain shows queried meningitis features. She did an EMG for him and showed a diffuse predominant motor axonal demyelinating polyneuropathy. Lumbar puncture, opening pressure 8 only, CSF white cell 5, glucose ratio more than 0.5, protein slightly high of 474 milligram per liter. And she gave a diagnosis of GPS, given 1 dose of IVIG, and at that point, she also had consideration whether could this be rabies. So she gave a call to us and discussed, and we decided to take over the patient to investigate for rabies, looking at the clinical progression of the patients, all right, and from the history. So he developed fluctuating level of consciousness while in the private hospital. His ABG showed type 2 respiratory failure. He was given BiPAP, but not improving. Patient was intubated on the 3rd. The next day, when we see him, he had loss of brainstem function, basically brain death. Investigation sent for rabies PCR, saliva was tested positive. Family members counseled and referral to palliative care was made. So when we asked about the history of whether he had animal bites before, the wife strongly denied. And as usual, we would try to look for any wound on his body, and we do see some wound on his right hand, but he is a laborer. So as you all know, laborer actually do have some form of injury, and the family actually attributed the weakness due to him carrying heavy woods 1 day prior to the event. All right. And but what significant history that we get is actually the area he comes from. All right. And number 2, he has 4 dogs, and he claimed that all dogs were vaccinated, but one of the dog actually died in June, and he's the one who deal with the body of the dog. So the dog was vaccinated in May for a 2nd time, and the dog age is 14 years old, and the dog died 1 month later. All right. So all this actually give us a clue that possibly he could have been rabies, and it was confirmed, and looking at the clinical progression of the disease. All right. So the real questions here is, in places where there has been reported dog rabies, is there truly no human rabies case? So I think it is very important. This a lot of the time, these patients are very the clinical manifestation of human rabies is very non-specific at times. And if you don't really think of it, you would actually just miss through the diagnosis. And as you can see, this patient actually goes through GP, goes through an orthopedic surgeon who might not have any inclination about rabies before. So they won't be able to diagnose. And as you can see, their clinical manifestation can manifest as anything like stroke-like syndrome, all those things. So we need to really look hard for these cases to be able to diagnose them. So another question is that in the absence of animal bite, can we safely rule out rabies infection? In fact, no, because at the time when the patient presented to us, a lot of time they can't give a very clear history of animal bite. And repeatedly, we have seen patients when now, for your information, any rabies death in Sarawak state, there will be a state mortality to look at what we can improve. And also we are looking at a One Health approach in which there'll be investigation to involve the public health, the vet, okay? So they'll go down to the ground to sample the animal. They will go down to educate the people around there. And usually you must find the correct person to speak to, because sometimes you speak to the wrong family members, they will not be able to give you any history of animal bite. But in fact, this patient could have an animal bite, in fact. And another thing is because of the poor awareness and because of their own animal, this patient actually brushed through the animal bites and think that it is nothing of significance. All right. So these are all the things that we are seeing all these years. So what is rabies infection? Is basically it's a zoonotic disease caused by rabies virus. It is a single-stranded negative sense neurotropic RNA virus, belongs to Rhabdoviridae family, can infect almost all mammals, including humans, but the natural reservoirs of rabies virus are dogs, wild carnivores, and bats. And in Sarawak, cats are tested positive for rabies as well, them being an ant horse because of a spillover from the dog population. And the major defining characteristic of rabies virus are its neuroinvasiveness, neurotropism, and neurovirulence. So how is rabies transmitted? It is basically transmitted through the saliva of infected animal following bites or scratches. But it can also be transmitted if saliva or brain tissue from a rabid animal contacts a fresh wound or mucous membranes like lining of the eyes, nose, mouth, and genitalia. And there has been reported cases of transmission through corneal and organ transplant, but no transmission of rabies have been documented from infected patients to healthcare personnel or household contacts or by fomites or environmental surfaces. All right. So there are two types of rabies. Basically the furious and the paralytic rabies. Commonly reported in the literature is furious rabies, make up 2/3 of it, and paralytic rabies. But when we analyze through the human rabies cases that we have in Sarawak General Hospital, in which we have analyzed about 29 patients, it is quite a fair distribution between furious and paralytic rabies. All right. Of course, in the literature, they mentioned that in furious rabies, the patient survives shorter because you are dealing with a much higher viral load of rabies virus as compared to the paralytic form. All right. And I'll show you here, it would be more clearer. So as you are exposed to the rabies virus, the incubation period is usually around 4 to 6 weeks. Okay, here it was written as 20 to 90 days. All right. And follow which the patient will develop a prodrome, a non-specific symptoms of maybe fever, lethargy. All right. And after that, they're followed by acute neurological phase 1 to 4 days, and death occurs 1 to 7 days. This death occurs 1 to 7 days is without any intervention, like if you intubate the patient, because if you intubate the patient, generally you support the patient a few days longer. All right. So as you can see here, furious rabies, they would have fever, pruritus, and paresthesia. All right. And what they show here is mainly furious, like the features of furious rabies, hyperactivity, confusion, as well as agitation. And a lot of times they would have features of hydrophobia, as well as aerophobia, dysphagia, hyperventilation, and even hematemesis. And they goes into coma. The terminal event is they goes into coma no matter whatever you do. Like the two cases that I shown you just now, even if you give them IVIG, it is a waste of money, and because they would still progress into coma. What about paralytic rabies? They would have prodrome, and then after that, they would present like a GBS, okay? Quadriplegia, dysatrial hypersalivation, inspiratory spasm, respiratory failure, and the terminal event, about 50% of the case, you might see hydrophobia or aerophobia. And by that time, they will be very drowsy, and is followed by coma and death, okay? So these are the natural progression of human rabies. So as you can see, rabies-like symptoms here, always consider rabies if you have animal contact, okay? Tissue or organ transplant, but frankly speaking, in Malaysia, we haven't seen that before. But I'm not sure if you get an organ from a Sarawakian transplanted. I don't know whether you have chance of getting rabies through organ transplant or not. I'm not sure. All right. And different diagnosis, differential diagnosis, you can see it can mimic autoimmune encephalopathy, toxic induced encephalopathy, metabolic electrolyte disturbances, illicit drug use, bacterial infections, other viral infections, and parasitic infections as well. So there's a lot of differential diagnosis, okay? So this one, I think I have mentioned, but I just want to touch about the incubation period. The incubation period in general is about 4 to 6 weeks, between 3 to 8 weeks, but in about 1 to 3%, you see their incubation period is more than 6 months. And the in fulminant, we will see that it occurs in 5 to 6 days. It all depends on the viral, the amount of virus inoculated at the time of bite, the inoculation site, whether there's a lot of innervation where there will be a direct nerve injury, density of the innervations, or if let's say in the head and neck region, the distance for it to reach the brain would be much shorter. All right. And usually the patients, like dogs, they would become infective a few days, a few days before the prodrome started and until the time when they died. All right. So what is interesting about rabies is that as the dog bites you, if the saliva is full of rabies virus, the virus would stays in the muscle here, and there will be a low replication rate, and it is like a smoothing period if there is no nerve injury, because the virus would need to proliferate locally and needs to make its way through the neuromuscular junction through the acetylcholine, nicotinic acetylcholine receptors. But if there is a direct bite, or if there is a deep bite into the nerve, then you gain entry into the peripheral nerve much faster. All right. So as it goes into peripheral nerve, it'll be about 50 to 100 millimeter per day. The virus would move, okay, and it goes up through your spinal cord, goes up to your brain, and comes down to the salivary gland. That's why you have virus in your saliva, in your lacrimal gland, and in your sensory nerve to skin, especially at the knuckle region. All right. So human rabies get bitten, incubation period 3 to 8 weeks. Human rabies, furious or paralytic, and 7 to 10 days, they'll be dead by then. All right. So what to do if you get bitten? Because generally this is a preventable disease. All right. So the most important thing is still wound washing, because after managing rabies for so many years, a lot of our patients, they wash the wound very chin-chai, meaning what they do is they just wash for about 2-3 minutes. They don't wash properly with running water and soap, all right? And after that, they consider it's done. So in the WHO document or any documents, you must actually wash the wound for at least 15 minutes with running water, with soap, all right? And this is the very essential part of wound management post-bite, all right? And it's very important, you should not suture, because if you suture without cleaning properly, number one is infection. Number two is, as you suture, you might embedded the virus much deeper and might hit the nerve as well, all right? And good wound care before the time where rabies vaccine is available can reduce rabies infection by up to 40 to 90%. All right. And what to do if get bitten? You see a wound like this, if you just wash for about 5 minutes, and of course, this type of wound is very, very painful when you wash it. So therefore, patients don't wash it properly. So it's very important. You must always emphasize to the ETD, they must actually irrigate the wound properly to wash off the saliva that contains the rabies virus. All right. And assess the wound properly. What is the WHO category of exposure? And look out for all the wounds and do not miss any. All right, I'll show you this. Okay, this is one of the bite wounds that happens on the face. Okay, it's a real patient. He was definitely bitten by a rabid dog, and this dog actually jumped on him and bite on his face. So if you look at here, this is just a very superficial scratch. So if the doctor didn't open up his mouth, you would not have seen that the dog have embedded 2 holes here. All right. And as you can see, there's a hole here. So what the doctor did was they get the dental in, then they help to irrigate the wound and then inject RIG into the wound. All right. And this patient still survived 1 year after the bite. Okay, even though the bite is on the face area. All right. So, and very important thing is that in countries or areas where it's enzootic for rabies. So in Peninsular Malaysia, it's not enzootic for rabies as far as I know, because you don't have, in a presence of good surveillance, you don't detect any dog rabies, but it is definitely endemic in Sarawak. So category 1 is that your skin is intact. You don't have any eczema, you don't have any break in the skin. And if the animal licks you or if you feed the animals, basically what you need to do is you just need to wash your wound. All right. Category 2 means nibbling of uncovered skin, minor scratches or abrasion without bleeding. All right. That thing, of course, if you look at the pathophysiology, it is not very deep. So in usual case, you would wash the wound properly, it would help. But vaccine is like a additional steps or to safeguard you. All right. But if it's category 3 where it draw blood or it is a very deep bite, okay, or lick on a broken skin, then you would need a vaccine plus RIG if the animal is at risk. Okay. So what to do if get bitten? You must first wash your wound 15 minutes. Then after that, you get assessment for vaccine plus RIG. So we come in our Sarawak state, we have come up to version 5. But I think when the questions that you need to ask when you assess a dog bite patient is, what is the category of exposure? And has the patient ever been vaccinated for rabies, either as post-exposure prophylaxis or pre-exposure prophylaxis? But must always get a proof of vaccination through vaccine card. And always ask, is the patient immunocompromised? Why is it important? Is because the way to manage an immunocompromised patient is different. When do I need to refer for urgent RIG and when should I give antibiotics? Okay, because we realize that one of the top users of antibiotics in clinic kesehatan is animal bite actually. All right. So basically, this is what I've spoke about. I won't go into it. But the greatest challenge in rabies management in non-endemic states, like what you all are facing, you cannot be giving everybody RIG or vaccine, because I don't know whether you have adequate supply. But I think the priority definitely would be in those states where there is it is bordering the Thailand border, where there might be a possibility of the animal infiltrating. But I think you have quite a good immune belt being established in that area, and there has always been an ongoing surveillance to see whether there's any animal rabies. So what is the greatest determinant to vaccinate or to give RIG? I think the animal status is very important. If it is a homebound animal, never mixed with stray, very up to date vaccination, even if the animal scratch you or bite you, this animal don't have any risk. All right. So it doesn't even warrant a vaccination or RIG. Characteristics of the bite, how the bite occurs. If you are playing with the cat suddenly scratch you, it is actually called a provoked bite, and generally, most likely, this type of risk is very, very low. A cat that is rabid or a dog that is rabid would bite unnecessarily, especially the cat. If the cat is rabid, without even playing, the cat would come and bite you. And when it bites you, it will not want to release, and you have to forcefully release it. Okay, this is a characteristic of the cat that has rabies. What about dog? A lot of times, dogs also the same. They attack you unprovokedly. And also, a very common scenario in which patient get bitten is that they thought the dog is knocked down by a car, or the dog is sick, so they give medication. That's why accidentally they are bitten. They thought because their dog are sick, that's why they are bitten. These are actually sounds like provoke, but actually if your animal is unwell, or if the dog is found at the roadside, the risk is very, very high, because if I don't know, you won't be able to see dog crossing roads very often in unless you are staying in kampong or in suburban areas. But in Kuching here, we always see dog crossing the road every day, and the dog is so good. Their coordination, they know about the, unlike cats. So if a dog get knocked down by a car, most of the time, I think the dog has lost its coordination, and a lot of time this dog have disease. All right. So do not touch this type of dog. And where the animal bite occur, and if the animal bite occurs in the areas where there has been reported cases of rabies, then you have to be very, very careful. All right. Definition of immunocompromised, I won't go into detail. You can find this in the literature. All right, it is quite common even in vaccine trial, all those things. The definition of immunocompromised is the same. So which patient that will need to give urgent RIG? Basically, head and neck, oral cavity, nose region. If the dog is high risk, multiple deep bite wounds over hands, genitalia, immunocompromised patients, and those who need urgent debridement, like their wounds with tendon cut, amputated digits, penetration into joints, fracture, injury into vessels, airways, or internal organs. All right. But we would only give an urgent RIG if we feel that the dog is really, really at risk and for rabies. Okay. In Sarawak, it is very endemic. Sometimes we would just give because it's very hard to differentiate unless it is a home dog that never goes out with a vaccination against rabies that they're able to show us. All right. So how to treat immunosuppressed patient? You have to treat them as treatment naive case all the time. So if they are category 2, vaccination. Category 3, vaccination plus RIG if indicated. Okay, what about in a non-immunocompromised patient who is recently vaccinated less than 3 months? You just need to perform wound washing and no need repeat PEP. So this one you can get it from WHO, and even in our national guidelines, I think that they do have it. Category 1, just wash the wound. Category 2, wound washing and either ID or IM. If you see ID, we give 2 sites, 0.1, 0.1, day 0, 3, and 7. But if you give IM, you have to give 4 times. All right, 0, 3, 7, 14 to 18. Category 3 exposure, you add on RIG. All right. So if for those who are less than 3 months post-vaccination and they are not immunocompromised, no need any PEP, just wound washing. All right. But if you are more than 3 months, then you basically just have to give booster. Okay. For booster, you can give intradermal 0.1, day 0, and day 3. Or for us, sometimes patient cannot come, so we'll give intradermal 4 sites, 2 at the both deltoid and 2 at the anterolateral thigh region. Or if you use IM, it will be 1 dose at day 0 and 1 dose at day 3. RIG is not indicated. Same with category 3 exposure, because once you ever had rabies vaccine before, if you have an animal bite and you're given a first 1 dose of booster, the antibody actually goes up very, very fast, almost immediately, but not in immunocompromised patients. So intradermal, we use intradermal in Sarawak. Okay, and if you give intradermal, you must see this bleb of at least 0.5 centimeter, all right, to say that it is an effective intradermal. Yes, same efficacy and immunogenicity. It is cost effective. It conserves the vaccine supply, make it more readily available. It is less painful. And very importantly, for certain group of patients where they have very thick subcutaneous tissue, if you use the IM method, you don't even, with the needle that you have, you can't even penetrate into the intramuscular region. All right. So who should get antibiotics? Antibiotics should not be given to everybody. So there are 2 types, 2 indications. One as prophylaxis. If as prophylaxis is for 3 days, for treatment infected wound, 5 to 7 days. And antibiotic is given as prophylaxis and is recommended within 8 to 12 hours. And it is based on 3 indications: high-risk bites, okay, with deep punctures from cats, dogs that may have penetrated joint spaces, bones, tendons, wounds that require surgical repair; high-risk areas like hands, feet, genitalia, face, skin, overlying cartilaginous structures or areas of poor circulation; and high-risk horse like those who are multiple comorbidities like poorly controlled diabetes, immunosuppressed asthenia, and decompensated liver disease. What antibiotics recommended is always augmentin. Alternative is doxy with oral metronidazole, stroke oral clindamycin. And for patients not indicated for antibiotics, we'll ask them to be given flavin, wash BD for at least 3 to 5 days. And if you have money, you like betadine, so you can go to pharmacies to buy betadine solution. That is even better, okay? That is very important. And always advise patient that if, let's say, the wound is increasing painful, inflammation, fever, discharge, no improvement, they have to come to see us, okay? So by getting timely PEP and ISAF, all right? So the answer is no, actually, if the dog that bite you is rabies positive. I just show you two cases. So this is a case where this patient went to visit his brother in a housing area, and this is the first time she visited the place, and the dog came from behind, and actually she was without any barking, and when she saw the dog, she retreated and she fell down. As she fell down, the dog came and bite her on the scalp region, causing this injury, all right? And also bite her on the hands, bite her on the thigh region, all right? So definitely she went to a place in the town area where previously there has been reported animal rabies, okay? This is another case, 83-year-old lady. As you can see here, there's some wound, but you see this wound is caused by fall, but not due to bite from animal. This is her right breast. She actually was pushed down by the dog, and the dog dragged her and bite her on the right lateral chest wall, happened, and then drag her, okay, drag her a certain distance. So this is the worst part that is injured, all right? And these are when she falls down, she hit herself and get cuts, okay? So for her, it happens in her grandchild's house, all right? And the dog that attacks her is this dog, okay? You know what type of dog is this? This is a Rottweiler. Rottweiler is the second most dangerous dogs in the world. So it's known to be very dangerous. And this dog actually have been vaccinated and just recently undergo training. So it's very unstable. So that's why we didn't give this old lady RIG, but the first lady we give RIG, all right? So no treatment is 100% effective. The risk lies in animal bite. Why the answer is no is because it depends on the area of the body bitten. If you are bitten on the head and neck, because the duration, the incubation period will be shorter, then your risk will be higher before your vaccine takes effect. How good you wash or irrigate the wound, vaccine technique, and patient factor come early or adherent to clinic schedule for vaccine or RIG. So no rabies in dog, no spillover of rabies in cats, then there will be no human rabies. All right. So to sum up, we are facing a serious threat from rabies. The problem can be divided into urban areas where poor pet ownership leading to stress issue, pockets of people with poor awareness as well. In our suburban and interior place, the awareness is very, very poor. Okay. And we should learn from countries who are struggling to eliminate animal rabies. If you eliminate animal rabies, the source, you will not have human rabies. Awareness is a very important part of rabies management. And it is now endemic in Sarawak. So it is very important. If you get cases where patient was bitten in Sarawak, do not take it lightly. Very high chances that you are dealing with an animal which is rabid. And in states that previously reported animal rabies, ongoing animal surveillance is important, and clinician has to be vigilant in identifying human rabies case. For any healthcare facilities that offer rabies vaccination RIG, it is very important. The temperature of the to keep the vaccine intact is very important. It has to be maintained at 2 to 8 degrees at all time. Same with the RIG. Do not take out. If you take out, you have to immediately use it. Do not leave it at room temperature for a very long time. Proper wound washing and assessment is very important and key to prevent human rabies and death. Use antibiotic judiciously, because we are facing a global threat of AMR as well. We don't want to add to another problem. And for any patients presented with GBS or meningoencephalitis in Sarawak, especially if patient is male, come from rabies hotspot areas, think of rabies. Rabies must be excluded. All right. So One Health is very important. Elimination of dog rabies, zero human rabies death, then only then we can eliminate dog transmitted rabies, and we aim to have a zero by 30, meaning to end human death from dog mediated rabies by 2030. Thank you very much.
Thank you very much, Dr. Chua, for the excellent and very insightful talk, because I think not many, probably none of us have seen human rabies in our practice till now. We definitely would not want to see one though, right?
Yeah.
Okay, I must applaud your team of clinicians who have diligently looked for, the possible diagnosis in your index case and diagnose rabies, and then alert people about the endemicity of rabies. If you have any questions, please post it in the Q&A box. I think there's a Q&A box, or if you want to ask a question, you can put up your hand. I think there is a hand sign, and I think the organizer probably can unmute you if need to. We'll invite any questions if you have.
Dr. Kerr, we have two questions in the chat box.
Oh, okay. I can't see. Okay, you go ahead. Thanks.
Okay, so we have his question is, do we give vaccination and RIG in non-high risk area?
Okay, yeah. To answer that, it depends on whether your state is endemic for rabies or not. Like in Sarawak, where it is endemic for rabies, we would err on the safe side to give vaccination and RIG if it is truly indicated. In a non-endemic areas like what I've mentioned just now, not all patients you need to give vaccine and RIG. It all depends on your assessment of how the animal bite occurs. If the animal that bite the patient is relatively safe, it is not recently adopted, the animal is housebound all the while, the owner has a good pet ownership practice, okay, never leave the dog out of his sight, this type of animals, if it bites you, you only need to wash the wound properly and see whether antibiotics is indicated, and you don't need even vaccination or RIG. But of course, another area that you need to address is, of course, patients' anxiety. So if you need to give them something, I would only suggest it would be the vaccination. All right. Yeah. So the second question is, can an infected person with rabies transmitted the disease through human bite? Definitely it is possible, because the most sensitive sample for us to send for rabies PCR is in fact human saliva. So imagine if there's a lot of pooling of saliva full of rabies virus, if let's say the patients bite you, like an animal bite you, definitely there is risk of transmission if you don't carry out the appropriate PEP, like what you do for animal bite. Yeah. And another third question is how to deal with patient if they develop an allergic after vaccination. We hardly see any allergic to rabies vaccination, but I think if let's say it depends on how severe it is, and we can always manage them accordingly to the usual practice. And if let's say they really have a severe allergy, that means that we need to get back, maybe refer to our derm colleague to see whether it is appropriate for us to give the second dose or not. Yeah.
Okay.
Okay.
Next.
The last question is asking about the male gender. Okay, so from our review of all the 29 cases that died in Sarawak General Hospital, I think about 85%, 89% are male gender. So meaning I think the male mainly they are more exposed because of their work. They are contract workers, they work in the farm where animals are free roaming, or they have tendency to get bitten. And a lot of males are those that actually when they see dogs dying dogs being knocked down by cars on the roads, they'll be the one who stop the car and go and put the animals to the side, and that's why they get bitten. Yeah.
We have another question from Dr. Shahir Fudzi. He asked, in non-endemic area, if the patient got bitten by a stray cat, can we just prescribe antibiotic if the wound is severe, or should the patient monitor the stray cat behavior within 2 weeks?
I mean, if you are bitten by stray cat, chances of you monitoring the cat is very, very low. So I think the questions is, can we just prescribe antibiotic if wound is severe, or should the patient monitor the stray cat? So again, we have to look at the in non-endemic areas, like let's say you get bitten in maybe somewhere in Selangor, you go a coffee shop, you get bitten by a cat, and it is a provoke, like you try to feed the cat. I think the risk is very, very low. You just need to wash the wound, and if you think that is a very deep bite that warrants antibiotic, then you have to give antibiotics as prophylaxis for 3 days, or else don't give for 5 days. But if let's say if you are in a non-endemic place where suddenly a cat out of the blue without you doing anything come and bite you, and the cat don't want to release, this cat is definitely something wrong already. Yeah. So you have to actually be alert, because sometimes we tend to brush through things. And in fact, back in 2017, before we diagnosed the human rabies in the PIDS patient, I still remember we have some adult patients from Syrian, at least a few that comes through us with neurological issues, that we say, oh, very unlikely rabies, because we never seen rabies in our life. So it's sometimes we need to be more vigilant. Yeah.
Yeah, I think antibiotics in this sense is for prevent infection or treat infection. Antibiotic is not going to treat rabies anyway, right? So it's not related to rabies antibiotics prescription, right? Dr. Chua, can I just ask about what happened to all your human rabies? Any survival?
Okay. Yeah. We do have some survival, but we haven't fully analyzed our survival yet. But some of them do have received some post-exposure prophylaxis. Some don't receive post-exposure prophylaxis. As to why they truly survive, we still haven't really figured out. Yeah.
All right. So it's not 100%, right?
Yes. Yeah.
I mean, or those, but I mean, sorry, I mean the human rabies.
Yeah, human rabies, correct.
All right.
We do have some survival. Yeah.
Right. Without neurological deficit.
Yes. Yes.
Oh, wow, that's wonderful. Good news.
Yeah.
Wonderful. Yeah.
So another question is rabies vaccine indicated if patients get bitten by bats due to occupational related injury? Okay. So far, yeah. If bats, so far we haven't detected rabies in bats, in bats before. I think in the recent Selangor exercise where this is the first time I saw the vets really calm everything, and they actually tested about 20 bats sample, and all were found to be negative. So actually, I think bats, I will not give personally, but if the patient is very anxious and we cannot really calm him down, probably yes, but the answer is no at this moment, because based on our surveillance. Yeah.
Yeah.
Our last question is, did you notice the last question, Doctor?
Yeah.
So means it would be appropriate to get wound care team involved for monitoring if deep wounds.
I don't know what do you mean by wound care team, because I think because in our practice, the first entry when the patient goes to the clinic kesihatan or to the ETD, the wound washing is being done there. So the adequacy of the wound washing is at the point of patient's entry into the healthcare system. So I don't know whether the question is to say that whether the wound care team would follow up on the deep wounds, whether you get infected, all those things. Yes, I think definitely, because like the old lady that I show you where she was bitten very badly on the right side of the chest, the wound care team is involved in her care, because it is very tedious, and she stays for about nearly 2 weeks in the hospital. Yeah.
I think
I think it's 4 p.m. So thank you, Dr. Chua, for taking time from your busy schedule and sharing with us the very valuable informations and your experience in handling rabies. And must thank all the participants as well, and team from Hospital Taiping for making the event possible. Thank you very much, everyone.
Thank you, Dr. Chua.
Thank you very much.
Okay. Thank you. Bye.
Bye.
Thank you, Doctor.
Thank you, Afiq.
Thank you, Doctor.
Thank you.
To the participants, for this week or until further notice, MMA have enabled the QR code option. So for today QR code, for those who have attended, then this has been automatically been captured, and we will put it automatically into the MMA. So manually. So thank you and have a good day. No need to scan QR code today, okay?
Thank you, Afiq.
Welcome, Dr. Abinash.